Right, so total knee arthroplasty and Parkinson's disease, enhancing outcomes and avoiding complications. This is a sort of review/recommendation article from the JOS last year. The authors consist of 3 orthopedic surgeons, the first 3 mentioned, as well as a neurologist and an anaesthetist, all from Columbia State University Hospital. No conflicts of interest, save for Mr. McCauley, who has received grants from Wright Medical and Pfizer, which don't seem to conflict with anything mentioned within the paper. So the article starts off by giving a bit of an introduction, stating that Parkinson's disease is the second most common neurodegenerative disorder after Alzheimer's disease in both the US population and worldwide. The statistics they give are 0.3% of the population, which increases to 1.2% of persons aged over 65 and 4 to 5% of persons aged over 85 in the US. In comparison to some Australian and worldwide data that are dug up, there are some definitional issues in defining Parkinson's, meaning that the definition used in a lot of Australia studies actually includes a lot of Parkinsonism and iatrogenic-induced symptomatology, and rather than the world figures, which has quite a strict definition of Parkinson's, just down to about 1.8% of people over 65 years. Total knee replacement has proved a challenge in Parkinson's disease for a number of reasons, these being the musculoskeletal rigidity, tremor, contracture issues, as well as gait instability in the perioperative and rehabilitation period. So this article suggests an integrative, systematic, multidisciplinary approach to patients with Parkinson's disease. However, it does go on to state that the lack of evidence base and lack of published studies looking at this demographic of patients severely limits a review of this topic. And certainly a lot of the recommendations the paper makes clear come out of the clinical experience of the authors and what sort of makes sense rather than anything that could be backed up by good. A brief bit about the pathophysiology of Parkinson's disease. So it's a degenerative loss of dopaminergic neurons in the substantia nigra. Dopamine is a regulatory chemical that regulates inhibitory outflow from the basal ganglia, responsible for motor pathways. So you get disturbance of these pathways and no regulation, leading to the characteristic pill-rolling tremor and the other symptoms involved. Optimization of the disease is difficult because it is degenerative, and the cause at this stage is still essentially unknown. It has been associated with a number of risk factors. This paper mentions certain medications, toxins, and environmental factors. Some would argue that Parkinsonism induced by medications does not fall into the definition of Parkinson's disease proper. And other papers highlight links between herbicides, pesticides, and chemical exposures, as well as family history, certain genetic elements, drinking tea, and high cholesterol. There are also papers that show that current smoking is a risk factor, but past smoking is protective for Parkinson's. Maybe we should all start and then quit. Boxing, I don't know. We've got N equals at least 1 in that paper. Looking at severity ranking scales, and I must admit I've not heard of any of these or seen any of these used clinically. There's the Unified Parkinson's Disease Rating Scale, which looks at a number of factors as listed there. A Schwab and England scale, which has been recently proven to be less than ideal and not incredibly well validated, as well as the Modified Hernan-Yarn scale, which is the one used in this paper, which is a little bit vague than one may expect, moving from no sign of disease in stage 0 to unilateral plus axial, bilateral disease, and the different levels within that, down to wheelchair-bound or bedridden and less aided. These ranking system becomes very important when you're looking at indications for total knee arthroplasty. So most of the papers unfortunately state that total knee replacement or arthroplasty is less successful in Parkinson's disease, and the outcomes are relatively poor. These are probably the 5 major studies that have been done. If you look at the numbers involved, we realised the evidence is a very small base. The first paper actually published was a case series of 3 patients. 2 ruptured their quadriceps tendon post-operatively and all died within 24 weeks. Not really good for long-term follow-up. One was uremic, one had some sort of cardiac event, and the other was unknown. Vince et al. Went on to look at 9 patients. Interestingly, 4 of them must have had bilateral total knee replacements, the 4.3-year follow-up, but all were relatively mild disease, all in that 1 to 3 category, so not at the severe disability stage. Duffy and Truesdale in 96 looked at 24 patients, again a number of bilateral replacements. And this is the stage at which the evidence emerged that while total knee replacement is very good for, or indicated for pain relief, you don't actually achieve the functional status improvements in this group as you do in patients not affected by Parkinson's disease. Moving through the evidence then, you start to look at a lot of papers that show that posterior dislocation and instability is an issue, and that has implications for prosthesis choice, which we'll get. Then moving on to another case report. This is a patient who was written up in 2005, diabetic coma, UTI, recurrent flexion contracture, and this is a stage where botulism or Botox injection has started being used to relieve these contractures either when they occur or prophylactically. And again, we'll get onto that in a moment. So recurrent themes looking through all of these papers is problems with the extensor mechanism. Wound necrosis seems to be high risk in these patients, as well as post-operative confusion. You'll remember that Parkinson's disease is associated with its own form of Parkinsonian dementia, as well as Parkinsonian depression. And there's very limited functional improvement, as I've already said. This article then moves on to look at ways of avoiding early complications, and these are addressed from a medical perspective as well as from an orthopedic perspective. So it states that Parkinson's disease, it's difficult to say whether it is a complete or absolute contraindication to total knee replacement. You do achieve certain degree of pain relief, and the goal should be achieving that pain relief while minimising these complications, particularly extensor mechanism rupture. Multimodal approach definitely is required, and patient expectation and goals with regards to pain relief or functional improvement need to be very appropriately clarified with the patient and their family. So looking at the medical management of the underlying pain or functional limitation should be addressed first, as is probably arguably the case in any situation of degenerative joint disease. And some of these issues may actually be more appropriately managed with physical therapy and Botox to relieve any contractures that are present. If these measures fail, then total knee replacement can be considered. But if the limitations are purely functional rather than a significant pain component, it's probably prudent to reassess the pathophysiology of the condition, and 2, whether a joint replacement is actually going to assist. And certainly a perioperative plan from the patient's neurologist regarding timing and recommencement of Parkinsonian medications is vital. Indeed, neurological intervention preoperatively or on the day of surgery has been directly associated with a good clinical outcome in comparison to delayed consultation with a neurology team. And this paper was relatively well controlled for a number of other variables. This has implications for length of stay, as well as medium-term follow-up knee society scores. So I think the take-home message from this in our patients here is that patients with Parkinson's disease should be flagged at least in the pre-admission clinic, if not prior to that in the outpatient setting, and have proactive input from the neurology team rather than these patients being referred on day 1 or following their operation. And there needs to be a low threshold for triggering repeat consultation in the post-operative. There are changes in mentation deterioration in their neurological status, including delirium, as well as any questions regarding pharmacological management. intraoperative anesthesia and post